Thank you. I'd like to thank you also for inviting me, and thanks to all of you for staying so late and hanging out. I was happy to hear in the previous talks about thoughts about moving what we know from research into practice, and I would like to talk about how we have done that with a couple of practices aimed at helping parents work with their very young children who have autism. So my plan for today is to just talk briefly about what I mean by an evidence-based practice, give you a little bit of understanding of what we call implementation science, which helps us move these practices into the community, and then give you some examples of projects where we have done this with parent-implemented interventions, or where we are going to do it. But my theme for today really is partnership. That's been our focus in trying to help communities use practices that have been developed by researchers. And so partnerships between researchers, community providers, therapists, parents, and the people who fund or pay for the interventions. I'm going to try to remember to talk slowly. There have been many recent reviews in the United States of practices that work well for children who have autism up through adolescence and a couple with adults. The end of my slides, and I know you have them, have the resources for these. There may, of course, also be resources here in China and other countries where you're from with similar reviews. So my focus today is not on choosing a particular intervention, but more how to choose one that will fit your needs for your community or for particular children that you're working with. Some of the interventions that I will talk about today, because they're for very young children, combine elements of two evidence-based theories. One is the principle of applied behavior analysis, which has a very, very strong history, as you just saw in Dr. Call's talk, of research in the area of autism for a variety of behaviors. Some specific behaviors, such as the challenges that Dr. Call spoke about, as well as more comprehensive programs. For very young children, it also has become very clear that it's important to include principles from developmental science so that we can work on those core deficits of autism, the social relatedness, the interaction, where children are beginning to learn. As you saw in the first talk, where we saw how important attention is and interaction with other people. So these naturalistic developmental behavioral interventions are interventions that are now often being used with very young children. And the intervention examples I will provide today are examples of these. Some of the reasons that we have moved to more naturalistic interventions or using naturalistic strategies with young children with autism is because the research has indicated that this leads to better generalization, which means that children use their skills in more environments, and maintenance, which means their skills last longer than very highly structured programs that don't move toward natural processes. Again, you heard some of this in the earlier talk. We see more spontaneous use of language, communication, and social skills when the strategies that we as adults use are more natural. Increased understanding of the skills and increased motivation to learn, which then decreases behavior challenges by using those antecedent strategies. When we're talking about parent-mediated interventions that can be used in daily activities are much more acceptable to families and easier for them to implement. And today I'm talking about asking parents to use these strategies with their young children during activities throughout the day. So we want them to be things that the parents find relatively easy to use during trips to the store, during usual play with their children, and while they're doing daily routines such as dressing and bathing. There are many well-established naturalistic developmental behavioral interventions. This is a list of some of them. It is not an exhaustive list by any means. But again, there are some differences course, between these interventions, but there are also a great deal of similarities. And so one of the things as a community that we need to do is think about which might fit best with what we're trying to do in our particular community or with our particular child. And we can get really good at doing that particular intervention that fits our needs with high fidelity or integrity, so that we know we're doing it well, rather than picking and choosing from a variety of interventions. So when we talk about moving these interventions that have a great deal of research into practice, there have been some challenges. The first challenge has been, and this is true not just in autism, but has been shown in other areas of children's mental health, is that we often don't see the level of outcomes in the community as we do in research-based studies. And our goal, of course, is to help as many children as possible and for their outcomes to be very strong. And so when we think about why the outcomes aren't as strong, researchers will say, well, the community therapists, providers, teachers are not using our techniques correctly. They're not doing all of the portions of the technique, or something is watered down. And that may be the case. The providers, the teachers, the therapists, the parents are saying, well, you did your study with very few children in a very controlled environment. This is not what our life is like. We have to adapt the intervention because we have all kinds of kids coming to us in all kinds of situations, and the very controlled way that you presented your treatment doesn't work, okay? Also probably true. And so they're saying they need to make the adaptations in order to make the treatments work. And so what we've been trying to do with our work is to understand where this gap is between how the interventions need to be adapted and what we need to do to still make them have good outcomes for the children and make this meet. And luckily, in recent years, there has been a science coming about called implementation science that has allowed us some strategies for helping move these treatments into the community in a more successful manner. And we are learning from the medical field, we are learning from the mental health field, how to do this in the field of autism, which to me is especially complicated because of course our children are served in many different environments and have many challenges. So this is a model I'd like to share with you, developed by Dr. Greg Ahrens, when he is looking at how to take a practice and move it into the community. And we start by thinking about how to sustain that practice in the long term. One of the challenges we've had with research is that we have a grant or a project to study a particular intervention, and when that grant ends, we don't necessarily have a way to continue that intervention in the community. And so when we're starting our community-based work, we really want to think about how is that going to continue? Who is going to pay for this once the research grant is over? And so I'll talk a little bit about that. And I'll talk about exploring which intervention to choose and how to determine which might be the best fit for the population you're working with and the community you have. Next, after exploring, there's a phase of preparation where agencies, therapists, teachers, parents, funders need to get ready to actually use this intervention, and this takes some time. Training begins, and then we start implementing, and then once we're doing the intervention well, we can sustain it. But again, we're thinking about the sustainment right from the beginning. So, things we want to think about, factors that affect whether this intervention is going to sustain or not. The first is the intervention itself. Does the intervention address the behaviors that we need to address? This is very important, of course. Does it work with the age group that we are trying to work with? There's probably a different evidence-based intervention that will work with a 2-year-old than will work with a 16-year-old, right? Different settings call for different interventions. Special education setting, a mental health setting, an inclusion setting may require different strategies for different reasons. So we need to think about the fit of the intervention. We also need to think about who's going to provide that intervention. What kind of training have those therapists had? Have those teachers had? Is this an intervention that is something they need, or do they need a basic training first? Oops. And then who is going to fund that intervention? What are the requirements of the service system? In the United States, we have very specific requirements for some of our service systems about the types of interventions that need to be provided or the types of supports that need to be provided. So we need to make sure the intervention that we choose fits those service system needs. Then advocacy, what do parents think? What do the individuals receiving the intervention need? And how will this fit with their view? Because as you heard Dr. Call say, if it doesn't work socially in their environment, then it's not going to be used well. So I'd like to first talk about a project called the Bridge Collaborative that's been going since about 2006. And so these are many of my collaborators who I would have to thank. We are a team. And also to thank the National Institute of Mental Health and Autism Speaks and our Federal Department of Education, who have all funded pieces of this long-term work. This is a group that started, like I said, in 2006. And this is an example of a community-initiated intervention. So we had a community provider and some funding agencies who said, we are seeing lots of young kids coming to us, and their parents are getting news that they have risk for autism, maybe a diagnosis, but maybe just risk. In the state where I live, children can receive services when they have this risk. And the community providers and the people who fund intervention for very young children were saying, we're not quite sure what to do. We haven't ever seen children with autism this young before. So they came to our research team and said, what can the research tell us? And so we said, well, let's take a look. And remember, this is 10 years ago almost. And what we found was that there was very limited research at that time for what to do with this population of children. And there wasn't really any research about what worked in the community. So this is an example then of us saying, we have a problem we need to fill. We need to be able to serve these children in our community. We didn't have an intervention in mind, and we needed to choose an intervention. So I just wanted to share with you how we did that, because I think that might be helpful as you begin to choose parent-implemented and other interventions in your communities. So we wanted to gather together as many people as possible who would have input. So we gathered together medical doctors, speech pathologists, occupational therapists, insurance company representatives, government-funded representatives, psychologists, behavior specialists, teachers, lots of people, parents, individuals with autism, to help provide input into our group. And we started meeting about once a month, and we looked for these things. Our research group presented on what the evidence showed, both in autism and other infant mental health interventions, that we thought might give us an idea of what might work with this population. Our providers, who had a lot of experience working with young children in our community, told us what they were doing and what they thought would work. And the families on our team told us what they thought was really important to them in terms of an early intervention. And what we did was try to find things as much as possible that would overlap with what was valuable in each of these areas. Because our goal was to take those areas of agreement and find an intervention that would be acceptable to providers and acceptable to families, but also effective for children. So similar to when Dr. Cole was talking about a child who wanted the music on, if we just leave the music on all the time, it's not that helpful for her learning in other environments. We could probably develop an intervention that was acceptable and easy to use in our service systems, but it may not be effective. And so that's not useful for providers or parents either. They want something that's going to work. And also the researchers want something that people are actually going to use. So we were trying to come to an agreement to find what would be that practice. So we came together as a consensus that in general we wanted something parents could implement, because these children were very young and most of them spent a lot of time with their parents. We wanted it to be relatively brief because we also weren't sure, because they were at risk for autism, what the next steps would be. So we wanted the parents to learn an intervention that would get them started, while the therapists could also be thinking about what the next steps for good intervention for this child would be as they got to know them and clarified what was needed and what their diagnosis might be. We also wanted it to appeal to different types of therapists and parents so we could have sort of a unified program within our community. And at that time in our community, there were sort of two camps. There were people that were really wanting a behavioral intervention and those that were really wanting a developmental intervention. And at the time, there weren't a lot of choices of things that were combined. And so we really wanted to find an intervention that would appeal to both those groups, and they were both represented in our collaborative. We also wanted it to be fundable. So we didn't want to choose an intervention with a method or an intensity that our early intervention agency or our insurance companies wouldn't fund and families couldn't afford. So that was another one of our goals. So this was sort of our, here are the things in our exploration phase that we're really thinking need to be addressed by the intervention that we choose. So then we picked 3 interventions that we thought met these criteria, but they were a little bit different from each other, so we could get, out of our small group of 20, we wanted to get more input from our community. So we invited these 3 intervention developers to come on different Saturdays to our community, where we did a lecture like this with we invited providers and parents from a lot of different areas to come listen to the talk about the intervention. Then we had some of them come and talk to us for another hour after that about their feelings about the intervention. And we had everybody, about 150 people at each meeting, fill out a survey about what they thought about the intervention and how it fit. We also spent about a half a day with each of the intervention developers to talk about how we could train and sustain people in our community, how open they were to any adaptations we might want to make, and what kind of a fit it would have. So we put all of that information and gathered it in a variety of ways, and our research grant allowed us to do some analyses of that information. And because it was, people had choices in their mind going into it, we also had an outside facilitator with expertise in consensus building come help us make our final decision in a very systematic way. So we took all this information in, we carefully reviewed it, we discussed it, we had a person come help us, and we ended up choosing an intervention called Project Impact. And again, I'm not as concerned about the intervention, but really thinking about the process. I do like the intervention, but I also really want to think about which intervention might work for you. And the intervention developers were extremely willing to allow us to adapt the intervention and had methods for implementing the intervention in varied ways depending on the service system which was needed for our community. They also had a train-the-trainer model, which was necessary for our community as well. And so we were really excited about this intervention and did some pilot work with it. Some of the questions I often get when I talk about this community collaboration, questions from community members are, how do you sustain this intervention when the research grant is over? Questions from researchers are, how do you move your career forward if you're working with the community and things go slowly? So I just want to talk, let me talk a little bit about the intervention techniques first, and then about how we've addressed both of those issues. So this intervention works both developmentally to increase engagement and initiations through interactive teaching, and then teaches new skills using direct teaching and behavioral methods. So it was able to meet the needs of both of those camps of professionals and bring in both areas, and also allowed parents to experience both, so that when their child, if they needed additional therapist-driven intervention, they would really understand what was being provided and what their choices were. And so our outcome so far is that we've successfully pilot tested the intervention, found that therapists and parents were both highly satisfied with it, really enjoyed it, but they had some changes they wanted to make to it because at the time it really wasn't developed for toddlers, it was developed for preschoolers. So we made an adapted toddler manual that we simplified quite a bit, added a lot of developmental pieces that we felt were more appropriate with base communication skills that the initial manual didn't have. And we're really excited because we just heard from the intervention developers that I think they're going to incorporate that into their next publication. We found that children made nice progress. We did a very small pilot study. We've got 2 federal and 1 foundation grants, so now we've just finished training, using a train-the-trainer model. We've trained about 15 trainers who are now each training 5 therapists each in their community so that they can sustain this practice within their agencies without help from us. And so far, our results are looking promising. I don't have any yet with specific data, but our preliminary data look like they're really learning these strategies well. Government and commercial insurance is funding the intervention, which is extremely helpful. We've been able to publish peer-reviewed articles and book chapters, both led by our research team, as well as those led by members of our community team who are also writers. 30 community and academic presentations, again, some led by our research team members and some led by the community, some done jointly. And we now have a community training program with an online component and materials for sustainment within each of the agencies. Our next step, and we are just starting to enroll now, is to enroll children in a small randomized trial of children receiving usual care and children receiving this intervention to make sure what we've done is effective, because of course that's important before we teach more people how to do it. But I wanted to just provide this as an example of how we really work together with the community to choose the best fit intervention and get buy-in from the people who are funding it and the people who are going to use it. And this has made a very huge difference in implementation. And now we have 10 agencies in one community and 5 in another community already using this intervention in a systematic and sustained way. There are a couple of challenges that we've had with moving this intervention in the community because it is a parent coaching intervention. And so I just wanted to talk a little bit about that. The first is that typically with an intervention, maybe a research team develops the intervention and then teaches teachers or therapists to use that intervention with a child. And that's usually how interventions work in the community. But with parent coaching, the community provider not only needs to learn the intervention, but needs to learn to teach parents to use that intervention. And so one of the challenges with very young children with autism or with risk for autism that is unclear is that parents are in a very stressful time. They have a lot of emotion and a lot of feelings which may be different between one parent and another about what should be done and what are the issues with their child, or maybe they aren't sure there are any, that therapists really take on as they're either going into homes or families or coming into clinics for this intervention. Also, a majority of the therapists who are engaging in early intervention, at least in the United States, really are trained in working with very young children. That's what they went to school to do, that's what their training is. And now we're asking them to please train an adult how to work with this child. And telling them that the best way to do that is have the adult practice and get their feedback. Not having them directly work with the child anymore for a majority of the time. And so we've really had to add not just training in the intervention, but also training in adult learning, how to teach parents, how to coach parents in a way that is successful, in a way that helps them integrate the strategies into daily routines, which is a challenge, rather than just teaching the intervention. And so that is something that we're really looking at, the best way to do that, the best methods for teaching people parent coaching, and helping them decide if this is something they want to do, given that they went into this to really work with children. So that's one of the specific challenges around parent coaching. The other challenge for us has been staffing. So of course, our group came up with a list of things that we thought a person should be as they're working with parent coaching, because we felt it was a challenging time for families and that this was pretty hard. And so we had these wonderful ideas of somebody with a master's or equivalent sort of education, somebody with a couple of years of experience with autism, someone with experience working with very young children, and someone who already had experience with parent coaching. And these would be the people we would train in this lovely intervention. And that would be the thing that would make it really work well, because our trainers would be so experienced and be able to really help parents at this time move into thinking about what their child would need in the coming years. But the reality is, when we go into the community and talk to agencies who are providing the service, is that the training and education is really variable. So some agencies have people with lots of training and experience and education who understand autism and understand parent coaching, who can provide this service. And other agencies really have people with really varying levels. Maybe they have experience with child development, but not autism, or autism, but not with toddlers, or teaching children with autism well, but not coaching parents. And so we've really been thinking about how to provide training that will work for all these levels in a modular way, so that someone who has lots of parent coaching experience, for example, doesn't have to go through that training, but someone who doesn't has the opportunity to do that. And so that's one of the things we're really looking at now, which we probably wouldn't have known had we not been doing this work in the community. If we had been doing it in a research lab, we would have just had people who are graduate students or researchers with that experience. And so that's one of the things even our community collaborative wasn't quite prepared for until we started doing this research. So that's an example, that was an example of some time when the community came and said, we have this problem, we need to find an intervention. The other way we've done some research, and this is an example of a parent-implemented model, we've also done this with school-based models, is we have this intervention that we know works in a research setting, but now we really want to move it out into the community. And so the Early Start Denver model is an example of an intervention you learned about this morning that has some evidence. And we just got funding from the U.S. Department of Education to work with our early intervention government agencies to try to see if we can adapt the parent-implemented portion to be used in early intervention, specifically in rural and low-resource areas where families get very minimal amounts of service compared to more urban or high-resource areas. And so I think you guys saw these actually this morning, if you're here for Dr. Dawson's talk, basically showing changes when we're using the therapist-implemented Early Start Denver model in both cognition and adaptive behavior after 2 years of the program. There have also been several single-subject studies looking at the parent-implemented model showing some change over time in parent behaviors and child behaviors. Now we know that in these rural areas, they will not be able to offer 15 to 20 hours of therapist-implemented intervention. And so we're going to start with the parent-implemented intervention. I'm going to go past that one. So here's our process that we're going to use. We've just started this grant last July, so I'm really excited about it, and would love it afterward if you have input. We have 6 teams in different states throughout the United States, some in urban areas that have low resource populations, some with more rural areas, who have agreed to help us learn more about their early intervention system, what kind of intensity they can provide, what kind of training their providers have, what kind of training they will need. And so we're gathering that community input through meetings with these community groups, as well as surveys that people in each state will complete online. And then from that survey information, once we learn a little bit more about similarities and differences across the state, we'll do phone interviews to find out more about what families need. We're going to talk with families who are currently in early intervention with children with autism. We're going to talk with different types of early intervention providers, as well as agencies and the state directors of the early intervention service. So we can get all those different levels that I talked about. We're also doing some studies within our lab to try to look at what the key components of the intervention are, to try to simplify things so that when we go into these rural areas where we don't have a lot of time with parents, we'll be able to understand what the most important things are to teach them. We will adapt the model and develop materials and then pilot test whether or not this new model is still effective, because that's our challenge, right? Making it work and be effective. These are just the early intervention techniques. I saw yesterday that this manual has been translated into Chinese. That's very exciting. And we think we're going to need to group some of these different categories together and simplify them so that they work in the early intervention agency. But we don't want to lose any of the key ingredients so that the intervention is less effective. We want it to be just as effective. So what we think we're going to need to do is provide lots of examples of how to use the intervention within daily activities. A majority of the early intervention providers for children under 3 in the United States provide services in the home because it's a mandate, and so we need to make sure this will work in the home. Like I said, we're really looking for those active ingredients to make sure we're teaching the core components. We're certainly going to need to have some modules on the parent coaching process. In some states, they already have parent coaching training for their early intervention providers, and other states they don't. So we want this to be a separate training, kind of as needed, to keep the training as cost effective and relevant as it can be for each of the states. We're sure we're going to need to make cultural adaptations for different populations. We're trying to look at other methods of distance support and supervision, and looking there's been some lovely research in this in parent coaching as well as training. We're hoping to develop some web-based modules for parents so that in between visits, if the visits are not very often with their provider, they can look at examples of how to do the step that they're learning online or on their phone to supplement what they are already learning. And then we're working with the systems level to make sure that this is going to be a sustainable practice. Whatever we adapt it to will be able to be used long after the research is completed. So that's just an example of an intervention that we already have, how we might partner with the community to move that out. And so just some steps as people are starting to implement these interventions. So let me start with the exploration phase. The first step is to come up with a team of people, like we did with our collaborative, who are going to be stakeholders in this process. And the people on this team may change over time. But in the beginning, somebody who can make decisions about funding needs to be on the team, because it's very easy to come up with lovely ideas that then are difficult to implement if a decision maker is not on the team. People who are already using particular interventions or working with the population of choice on the team, local experts who can then be coaches in whatever intervention you choose, are very helpful. Having a local researcher on the team can help you look for outcomes. Of course, you want providers and family stakeholders as well as agency administrators on the team. And once you choose an intervention, having conversations with that intervention developer or the person who will be doing the training is very important. So putting together a team is the first step. These websites that you have in your handouts have very detailed information on setting up an implementation team. Then you really need to think about the needs, resources, and capacity of your community at different levels. So at the larger system and agency level, we need to think about laws and policies, what population we're talking about, what are the leadership skills of both the directors and the agency leaders, where are the service gaps, what do you already have available and what do you need to fill in, and who's going to fund this service, and who is also going to fund the training, because the training takes time. At the agency and provider level, we need to think about what their access is to the materials and technology they'll need for whatever intervention you choose. Where are the gaps in their systems and training that might need to be filled? And how do they feel about learning new and innovative practices? Because again, if they aren't excited about it, it's going to be difficult to get them to do it well. And so helping understand what would work well for them is very important. Also thinking about provider education and discipline and who will be implementing the intervention. Some interventions are only to be done with particular types of therapists, and so you want to be careful that the people that you're choosing to do the intervention is a match with them. And then of course, family needs, how they perceive service quality, what they think of as quality service, cultural needs, the kinds of support they already have. Will they have transportation to the center? Do they have family who can watch the siblings? One of the things families said in our groups was, we want our siblings involved in the treatment because they are part of our family and we need to implement this as a group. What are their expectations, especially for parent-implemented interventions? Often families come with the expectation that an expert will work with their child for however the time period is, and then they will pick them up. And if that's the expectation, when we say it's time for you to play or learn this, it's just not clear and can be very confusing and awkward for the family. So we have developed some pre-treatment videos and handouts to help families understand, here's what we're going to be doing, and here's what you can expect from your treatment sessions. And then, do they have the time to implement this? Would there be another caregiver that would be more appropriate? Is it better to do an intervention in a preschool or daycare setting? These are the kinds of things when you're considering an intervention that need to be understood. Does it need to be a combination? And which intervention fits with that? And then thinking about the treatment. First thing, of course, is does the treatment have evidence? Does it have a way to measure treatment integrity? How can we tell if we're doing this correctly? Very important. Was the evidence from a population similar to the population that you want to work with? And has it been used in diverse cultural groups? There may not be evidence for that, so you may need to test it. Does it fit, again, with your system, your community, your family priorities, with the type of organization that you have, with what your providers already know and the values of the community? So some of these interventions have slightly different emphases, and one may fit better than another, even though the evidence is similar, and so you'll want to look at that. How ready is this intervention for training in the community? Are materials available? Can you find someone to train people in your community? These are really important things to know. So once you've explored that, then you want to think about preparation and implementation. And there are a few things just to think about, especially what leaders can do. And again, this is Dr. Greg Ahrens has done a lot of work in this area, looking at what makes it so teachers and therapists can actually learn an intervention. And one of the things is having a leader who believes in that intervention, who will support the training, who will provide the support and technologies needed to make that intervention work. It's very difficult for a lone therapist or teacher to learn an intervention without some support. Linking the use of the intervention with treatment integrity to improved outcomes for children by a leader can very much help a therapist or provider use the intervention well. Most people went into their business of teaching young children because they wanted to see children do better. And so if we can link the strategies and show them, look at the changes you're making in kids when you use these evidence-based strategies, and of course we want to measure that to make sure it's true, then that will be helpful in helping therapists get the buy-in they need to learn something new, because that can be challenging and hard. Also getting feedback from the people who are using the intervention. Is it working? What do we need to change? How can we provide the support you need is very important, rather than simply mandating the use of it. Along those same lines, rewarding people for using the intervention correctly and well over time is also helpful. So if therapists are supposed to learn a new intervention and they're supposed to be checking whether they're doing it right, but there is no consequence or reward for that, the incentive to do it is limited. And so what leaders can do is build into their system the support for doing it well, and then also the reward for therapists who follow through with that. And again, providing coaching and supervision, peer supervision, access to experts for help when needed, especially with challenging clients, is really important. Time is also very important, and this is one of the challenges that we've had, even with members of our Bridge Collaborative who want their therapists to learn the intervention. It can be expensive because training time isn't necessarily billable time, at least in the United States. And so providing the time needed to learn an intervention well is important. And then measuring whether you're doing it correctly. So sometimes we may need to adapt an intervention, but we don't know how we're adapting it unless we're first measuring what we're doing. We don't know how those changes affect child outcomes unless we've measured those changes. And so first we need to learn to do an intervention the way the intervention developer says, and then we need to measure any systematic adaptations and look at how that affects child outcomes. Really important for each agency and each child to think of, with each child to think about that. Because of course we're going to need to make adaptations, but we want to make sure they work. And then of course, bringing those information and changes back to the group so they can be systematic across an agency, right? So if one person is saying, gosh, I need to change this particular element because this family can't do it for X, Y, Z reason, another person may have the same challenge. And if everybody is measuring how they're making that change, we can see if it's an effective one. Also, someone else may have an idea of how to make it work. I'd also like to encourage community folks to have researcher involvement when possible and encourage researchers to get involved in these community programs. It can be beneficial in both directions. We have had providers teach us wonderful things about what we need to change and how we need to adapt our interventions. We've been able to take those suggestions and ideas back into the lab and test whether they're good or not good, and oftentimes our providers are quite spot on and correct. It also has provided our agencies funding for training. As we're testing new training methods, it also gives us the opportunity to train people and provide intervention at either low cost or no cost for families and agencies. So it's been a very nice bi-directional system. And that is all I have. So I hope that gives you some information about how to think about implementing some new interventions and parent-implemented interventions. And I look forward to seeing what happens here.